Welcome, everyone, to the weekly Neurology Deep Dive, produced by Amir Gabanini. Our goal, as always, is to take complex neurological research and, break it down into clear, actionable insights for you. Before we jump in today, just our standard but very important note. This discussion is purely for educational purposes. We don't have any commercial goals here. Think of this as a summary of the source material. And we really do recommend you read the full papers yourselves to capture all the nuance and the complete data. Okay, so today we're looking at two really significant papers on the long-term fallout from head trauma. Specifically, we're exploring traumatic encephalopathy syndrome and the risk of dementia after traumatic brain injury. And let's be clear up front. These studies, they're not focusing on minor concussions, someone just bumping their head. They are looking carefully at more severe or repetitive head impacts. That's a key distinction. Right? For those of you needing the clinical takeaway right away, here's the practical summary from today's deep dive.
Okay, first point. A history of traumatic brain injury does significantly increase dementia risk, particularly for vascular dementia and unspecified dementia. The link with Alzheimer's disease seems less clear based on this data. Second, this risk isn't static. It's higher if someone has had multiple traumatic brain injuries, and also, interestingly, if the traumatic brain injury happened at a younger age. Third, severity matters. More severe forms, think intracranial injury or skull fracture, show a stronger tie to dementia risk than isolated concussions do. And finally, while clinical features that look like traumatic encephalopathy syndrome are pretty common after any significant traumatic brain injury, the formal consensus-based diagnosis of traumatic encephalopathy syndrome itself currently hinges on having evidence of repetitive head impacts.
Excellent summary. So with those key points laid out, let's really unpack the research behind them. We'll start with a 2025 study by Dams O'Connor and colleagues. They explored traumatic encephalopathy syndrome within the late effects of traumatic brain injury cohort, the LETBI study. Now, traumatic encephalopathy syndrome is generally seen as the clinical side of chronic traumatic encephalopathy changes in the brain, typically driven by repetitive head impacts. But this paper asks a crucial question. What about people with just a single significant traumatic brain injury, some of whom might also have had repetitive head impacts?
Right, it's a really interesting approach. They did a secondary analysis using prospectively collected data from that LETBI study. This is a community-based group, people who had experienced complicated, mild, moderate, or severe traumatic brain injury. They looked at 295 participants. The mean age was around 53, and about 36% were female. And critically, about 47% of them, so nearly half, actually had enough repetitive head impact exposure to meet the formal criterion for traumatic encephalopathy syndrome.
Okay, nearly half met the RHI exposure criteria. So in that whole group, how common were the core clinical features we associate with TES, like cognitive issues or behavioral changes?
They were surprisingly common across the board. In the full sample, about 57% met the core criterion for cognitive impairment. Around 33% met the criteria for neurobehavioral dysregulation. And about 46% reported that their clinical features were progressing over time. So these chronic problems are quite prevalent after TBI.
Those numbers are high, 57% with cognitive impairment. So then how many actually met the full consensus criteria for traumatic encephalopathy syndrome, the ones requiring that repetitive head impact exposure?
Right, when you apply the full criteria, including the mandatory repetitive head impact exposure. Overall, about 15% of the entire LETBI sample fit the bill. They had substantial RHI exposure and all three core clinical features.
15%, okay. Now here's where it gets really interesting, as you mentioned. What did they find when they experimentally lifted that RHI criterion? Did people with only a single traumatic brain injury still frequently show that cluster of symptoms?
Yes, and this is a really key finding. When they removed the repetitive head impact exposure requirement from the definition, a substantial portion, about 34% of the participants who had only an isolated traumatic brain injury, still met all the core clinical criteria. It strongly suggests that the chronic, sometimes progressive symptoms after a single bad hit can look very much like traumatic encephalopathy syndrome clinically. Even if, the underlying biology might be different, it complicates the diagnostic picture.
It certainly does. So could they predict who was likely to meet these core clinical criteria based on demographics or injury details, like with severity of the single TBI predictive?
You'd think so, but no. Surprisingly, the study found that none of the injury or demographic variables they looked at significantly predicted who would meet all three core clinical criteria. The odds ratio, for instance, was 3.02, but the p-value was 0.10, so not statistically significant. It implies these symptom clusters aren't easily pegged to specific baseline characteristics in this particular cohort.
Interesting. What about functional dependence, and did they see different patterns of other medical conditions, comorbidities between the groups?
They did. First, function. Only about a quarter of all participants were functionally independent or just subtly dependent. So chronic impact is the norm here. Now, comorbidities. This was interesting. Those who met the full traumatic encephalopathy syndrome criteria, the group with repetitive head impacts, they had the highest rates of things like ischemic attacks, about 8%, migraine quite high at about 46%, and joint disease around 42%. But conversely, those who met the core clinical criteria without the RHI exposure, that group had the highest rates of other conditions, like epilepsy, about 14%, sleep apnea, about 24%, and hypertension, around 22%.
So different comorbidity profiles potentially hinting at different pathways.
Exactly. It suggests different underlying factors might be at play in these symptomatically similar groups.
So bringing this back to the clinic, what's the main takeaway for practicing neurologists from this Damso-Connor paper?
I think the core message is that it really reinforces why repetitive head impact exposure is so central to the current consensus diagnostic criteria for traumatic encephalopathy syndrome. While we absolutely see patients with single traumatic brain injuries who develop very similar chronic progressive symptoms, these findings support keeping repetitive head impact exposure as a key factor for the formal TES diagnosis right now. It helps differentiate, potentially, but it definitely raises a big question for the field. How do we refine our criteria to better capture all these diverse chronic outcomes after head trauma, regardless of the RHI status?
A very important question indeed. Okay, that sets the stage nicely for understanding the clinical syndrome. Now let's broaden the view. Let's shift to population-level risk with our second paper today. This is the 2025 study by Simmons and colleagues looking at dementia risk after traumatic brain injury, including different dementia subtypes in the whole Welsh population. A huge study.
It really is impressive in its scope. They use the Secure Anonymized Information Linkage, or SAIL databank in Wales, pulling electronic health records. We're talking over 20 years of data, covering about 1.7 million people. They zeroed in on individuals aged 30 to 65 back in 1999 who didn't have dementia at that point. The final cohort included over 42,000 people diagnosed with dementia and over 10,000 with a history of traumatic brain injury. And roughly half, about 49%, were female.
That's a massive data set. So what was the main finding? Did traumatic brain injury increase dementia risk overall in this population?
Yes, clearly. The study found a strong statistically significant link. Having a history of traumatic brain injury was associated with more than double the risk of developing dementia. The hazard ratio was 2.32 and the p-value was less than 0.01. So a very robust association.
More than double the risk.
Yep.
Did having more than one traumatic brain injury increase that risk even further?
It did. The risk climbed higher for people with multiple traumatic brain injuries. The hazard ratio for multiple versus single TBI was 1.22, also with a p-value less than 0.01. So repeat injuries definitely compound the risk.
And what about the age when the traumatic brain injury happened? Did that play a role?
A significant role, yes. The effect of traumatic brain injury on later dementia risk was much stronger if the injury occurred at a younger age. For people who had a traumatic brain injury before age 60, the hazard ratio for dementia was a striking 6.4.
Wow, 6.4.
Yes, p-value less than 0.01. Compare that to those injured at age 60 or older, their hazard ratio was 1.62. Still significant, p less than 0.01, but much lower than for the younger group.
That suggests a real vulnerability, perhaps, in the younger brain, or maybe just more time for consequences to develop.
Could be that or both. It certainly highlights that early life TDI carries a very heavy long-term risk for dementia.
What about the type of traumatic brain injury? Did they see differences between, say, concussion and more severe injuries like skull fractures or bleeding in the brain?
A very clear difference emerged there. The dementia risk was substantially higher following more severe injuries. For intracranial injury, the hazard ratio was 2.48. For skull fracture, it was 2.06. Both highly significant, p less than 0.01. Now compare that to concussion. The hazard ratio there was only 1.01, and the p-value was 0.981. Essentially no statistically significant association found in this study.
No link for concussion in this data set.
Not a significant one, and it's really important to understand the context here. Most of the traumatic brain injuries recorded in this Welsh data set were serious. About 69% were intracranial injuries, about 23% were skull fractures. Only about 8% were coded as concussions. So again, this reinforces that we're primarily talking about the impact of moderate to severe traumatic brain injury here, not simple concussions.
That context is crucial. Okay, let's look at dementia subtypes. Did traumatic brain injury increase the risk for specific types like Alzheimer's disease or vascular dementia?
This was another key part of the analysis. They were careful to exclude traumatic brain injuries that happened within a year of the dementia diagnosis, to try and avoid reverse causality. After doing that, the association between traumatic brain injury and specifically Alzheimer's disease was not statistically significant. The hazard ratio was 1.44, but the p-value was 0.189.
No significant link to Alzheimer's. Interesting. What about other types?
Yes, traumatic brain injury was significantly associated with unspecified dementia. Hazard ratio there was 1.90, p-value 0.0011. And for vascular dementia, the hazard ratio was 1.71, with a p-value of 0.027. Now, technically, this wasn't significant after they corrected for multiple testing. But the trend suggests a potential link, perhaps stronger than the link to Alzheimer's disease. It points more towards vascular pathways or less clearly defined dementia processes.
So putting this huge population study into perspective for clinical practice, what's the main message?
I think it provides really solid population-level proof confirming what we've suspected. A history of traumatic brain injury, particularly if it's severe or involves multiple events, significantly boosts long-term dementia risk. The fact that the association seems stronger with vascular dementia and unspecified dementia really highlights how important managing vascular risk factors might be in our TBI survivors. Things like hypertension, diabetes, cholesterol, these might be even more critical in this population. And it raises a practical question for all of us. How do we best weave this knowledge about long-term risks into our patient counseling and our follow-up strategies?
That's the key question. Okay, let's try to synthesize these two studies.
Yeah.
We have Dams O'Connor looking closely at the clinical picture of traumatic encephalopathy syndrome and the role of RHI. And then Simmons giving us this broad population view of dementia risk after TBI. How do they fit together for neurologists?
I think they complement each other quite well. Dams O'Connor clarifies that even without meeting the strict RHI criteria for formal TES, patients with single significant traumatic brain injuries can develop very similar chronic progressive symptom clusters. The clinical presentation can overlap. Then Simmons comes in with large-scale data showing, yes, these significant TBIs do carry a real, quantifiable long-term risk of developing dementia, particularly dementia types perhaps linked to vascular damage or other non-Alzheimer pathways.
So boiling it all down, what are the most critical practical takeaways for neurologists listening today, things they can apply in clinic tomorrow?
Okay, 4 key points, I think. First, detailed history is paramount. Ask about all head trauma. Get specifics on severity. The type, was it intracranial, fracture, concussion, and how many times? Second, recognize and communicate the risk. A history of more severe or multiple traumatic brain injuries significantly raises long-term dementia risk, especially vascular dementia. This needs to inform our follow-up vigilance and patient conversations. Third, remember the severity threshold. These studies strongly suggest the risk is driven by complicated, mild, moderate, severe TBI or significant repetitive head impact. This isn't primarily about simple concussions or minor head bumps. And finally, think public health. These findings highlight a real opportunity. Better TBI prevention strategies and proactive, vigilant, long-term management of survivors could potentially reduce the future burden of dementia.
Excellent points. Let's quickly recap that practical summary one more time for everyone.
Sure. 1. History of traumatic brain injury boosts dementia risk, mainly vascular and unspecified dementia, less clear for Alzheimer's disease. 2. Multiple traumatic brain injuries or injury at a younger age increases that risk further. 3. Severe injuries like intracranial bleeds or skull fractures carry higher dementia risks than isolated concussions based on this data. And 4, TES-like symptoms are common after TBI, but the formal traumatic encephalopathy syndrome diagnosis currently requires evidence of repetitive head impacts.
Perfect. And just a reminder, all this is for educational purposes. Please do read the full papers by Dams O'Connor et al. And Simmons et al. For the complete picture. So to leave you with a final thought, we've seen the clinical overlap between post-TBI syndromes and TES and the links to dementia risk, particularly non-Alzheimer types. Given these diagnostic challenges, how might future advances, perhaps in advanced imaging or maybe fluid biomarkers, help us better pinpoint who's truly at highest risk for specific dementia subtypes after traumatic brain injury? And could that ultimately guide more personalized targeted therapies down the road? Something to ponder. Thank you for joining us on this weekly Neurology Deep Dive, produced by Mayor Gavanini. Until next time, keep exploring, keep questioning, and stay well informed.